patient that's on APRV. Previously, the Phigh was at 34, and it's been at 34 for quite some time. The patient initially had a lot of weight. The patient's gradually lost some weight here, and the Phigh was at 34 initially, and there was really some morbid obesity occurring, so we were not concerned about going past 30. As Draeger company itself says that sometimes with morbid obesity, pressures even above 35 in APRV may be required to maintain or to recruit the lung. Right now we've decreased it using the Pulmovista, and we have the tomography continuously going at the bedside while we wean down from 34 to 33 and then to 32. So let's just go over to the Pulmovista and see what kind of information we can extract from the continuous tomography when we are trying to wean the Phigh in APRV. Okay, so now we're looking at the Pulmovista from Draeger here. Initially, when we were at a Phigh of 34, we took a reference. So that means that over here, this is the reference on the bottom of the screen. We have the dynamic image, breath per breath, and we have the tidal images, the changes that would occur between the dynamic, breath per breath, and the reference that we want. So you'll notice on the Pulmovista here, when you press the reference, you're going to have these lighter. So over here, you're seeing the 4 regions of interest, and when you do press a reference number, then you're looking here, the lighter, smaller numbers, that's really the reference. And this is what's actually going on at the moment. When we're talking about the 4 regions of interest, it depends how we're setting it up. But you see here that we've set it up as layers. So 1, 2, 3, and 4. This being the top of the chest, what we would usually call the ventral area. We have the mid-ventral area. We have the mid-dorsal, and then we have the dorsal. Now, assuming that the patient is supine, this would be the gravity-dependent areas where the blood is flowing here, and we want to get the make sure that there's some aeration. Now, the norm is 8 to 15, and then I might be wrong, but it's 35 to 40 or 35 to 45. And this one also is usually 35 to 45. And then down here, just like a region up here, is 8 to 15. And we see that this patient has 8% here, so 8 to 15. So they're within normal limits. Okay, so we're going to go to the view here, and we're going to look at the different options here. We have the full screen. So it just gives a wider view, maybe if you're outside of the patient's room and you kind of want to have a larger view. So that's kind of cool. The next view over here, guys, let's press that. Sorry, I'm trying to hold this phone camera while I'm doing this. Now, this screen here is End Inspiratory Trends, okay? So what we do here is we can control 2 aspects. We can control the reference, and then we can set the control. Now, let's just spin these 2 together. Okay. So I did the reduction, and usually without the Pulmovista, what we're dealing with is looking, okay, well, we reduced the Phigh, and let's hope the SAT doesn't go down. If the SAT goes down, then usually we would increase it. Now, as we know with the COVID patients, there is mainly a vascular issue and an interstitial issue. So there's a poor capillary blood flow, whether it's from microembolize or capillary congested. And we also have evidence that there's interstitial area between the capillaries and the alveoli that are also damaged, as well as alveolar type 1 pneumocytes and type 2. So up here again we have the reference, and then after we have the control. So I'm going to start by pressing the control here. Again, sorry about the camera shaking. I'm doing my best, guys. So we're going to start going here, and I'm going to be looking here. So look, I reduced the P high, okay, from 34 down to 33 and then 32. Now, up here in the screen, if there are changes, they're going to appear orange, okay? So you're not seeing much change, which is really good because we're showing at the moment that we reduced the P high, but we're really not losing any of the lung expansion at the end of inspiration. So that's telling me, okay, let me see if I can get close because sometimes it's very see, look at this, okay? So we ended up reducing the P high by 2 units of pressure. We're actually getting better volumes by almost 25 mLs from 400, 375, 380 that was going, and now we're well 400. Sometimes we're hitting some 415, sometimes 425, and you can actually see if you've connected the Pulmovista through the Medibus that it'll also understand what's happening on the vent. So you're actually seeing what's happening with the tidal volume. We're in APRV, so there's no peak, but the P high gives us the information. Okay, so let's just go to the next screen. So let's go to view. Let's check the next one. This is end expiratory lung impedance. Okay, now impedance. This is an electrical impedance tomography. So what happens is with these electrodes going across, when there's air, it impedes the, when there's air, there's a lot of impedance for the current going across in these vectors. And when the lung expires, there's less impedance. And that's how the tomography machine gives this dynamic image of the distribution of ventilation. Now we can use this on intubated patients as well as just spontaneously breathing patients. So with the COVID issue, if you look at some of the articles, I think published by the Italians, they talk about type L and type H. So COVID pneumonia or COVID ARDS cards, sometimes it's referred to CARD. They basically say that often they show up with normal compliance, good distribution of ventilation, good elastance, a nice supple lung, yet they're hypoxic. So by using the tomography, we don't have to do a CT scan to see what phenotype they are. Are they the COVID, the type L, the non-traditional, or are they the H, the traditional that we're used to? As you can see, even though the criteria almost for ARDS, the hypoxic factors, even the X-ray presentation often looks like a ARDS, but we're not getting the baby lung effect. Now, mind you, don't forget this is actually an obese patient, so this is a very good distribution. Okay, and obviously it can be a little better over on this side, but this is the best actually that I've seen this patient. Now, let's go to the end. Okay, end expiratory lung impedance. So end expiratory lung impedance over here. Okay, the same thing can be done with the Pulmovista by using the reference number as well as the control. So let's start over here. Let's bring it. So obviously in APRV I've reduced the P high. Okay, and that often has obviously an effect with the P low. Now, give me a second. I'm going to go to the other ventilator. So, if you notice here, FiO2, slope, P high, P low. If you're wondering why the P low is at 0, that's actually the setting. If you're looking here by freezing the waveform, if you're measuring this area here, that will give you a P low of 5.3. Sorry about that, let's freeze it again. Let's go over here. Okay. So now we have here, it's saying, hey, this is a P low of 5.4. This is actually not measuring the lung pressure. It's actually measuring during the brief releases the circuit pressure. Therefore, you have to close the valves, and we do that just like any test of intrinsic PEEP. We're going to go here on the Draeger. I don't suggest you use the PEEP intrinsic here. We're going to do an expiratory pause, okay? So I'm going to go over here, okay, and we are going to create, boom, plateau. This is actually the pressure when we're using the Draeger ventilator. This is actually the pressure over here. It's actually 10, okay? So this here, we set at 0. Now, if you're interested in understanding what the option here on the Draeger, this auto release, okay, that determines when this release stops and that we return, is basically looking at the peak expiratory flow, and I'm telling it, I'm going to allow you to expire, but when it descends to 80% of the peak expiratory flow, I'm going to, I want you to go back up to the high level over here. Okay, oops. So let's go back here. Sorry, very shaky. There's the auto release option. Okay, now if we didn't have the auto release option on, then we would either have to set the PEEP. We could set it this way over here, or what we would have to do is freeze the waveform. We would have to look here on the flow time waveform, and we would check the peak expiratory flow, that's 42. We'd have to multiply the 42.3 times 0.75, and then after we would realize the timestamp here, and we would go to 75%, okay? Let's say 75%.
Hey guys, so I'm just gonna briefly stop the video that I was presenting with, because I was making an error in relation to APRV when I was discussing the auto release option, which allows you to adjust the expiratory termination, meaning we're not necessarily we're not setting a P low level like in traditional APRV modes. We're creating a P low level by deciding how much we're going to allow the patient to expire from the P high level to a P low level. And we're determining that P low level instead of, as I just mentioned, a setting. What we're going to do is we're going to tell the machine to look at the peak expiratory flow on expiration, and we're only going to allow it to descend to a certain percentage of that peak expiratory flow. I was repeating over and over 75%, 75%. The reason is that 75% is usually the gold standard that offers the maximum alveolar recruitment as well as stability. This patient has been ventilated for a couple of weeks now, so we slowly crept it up from 75 to 80. Traditionally though, we'll start and we'll get to 75, and that's adequate. So I'm just so used to never going above 75 that even if you see while I'm explaining, I'm repeatedly saying 75, 75, and the knob says 80. So I'm already trying to briefly explain quite a unique concept on Draeger's vent, this auto release option, and here I am explaining it, and there's a knob that says 80 and I keep on saying 75. So when I'm saying over and over 75, forgive me, it's actually I'm meaning for this particular case with the setting, as you can see on the video, it's 80. So when I'm telling you that we're creating a P low setting, what I'm saying is let's just use 100 liters per minute for simplicity. If the peak expiratory flow upon release to that lower level initially is 100 liters per minute, and the expiratory termination percentage is at 80, then I'm only allowing the expiratory phase to go from its initial 100 liters down to 80. That's a very, very brief exhalation. So that's what I was trying to explain. So Forgive me while I'm saying 75, just put it in your head that I meant 80. All right, thanks a lot. Let's continue with the video. Thanks.
It was 27, okay? And see, it stops it. See, this thing here would just continue expiring almost like a flow rate, but we stopped it here. Now the vent's doing this calculation usually with the auto release on. If it wasn't on, we would actually have to do the calculation ourselves. So it's a unique option on the Draeger vent. Now 75%, there's evidence, especially the research done by Dr. Nadir, 75% usually has optimal recruitment. Now I've also realized that when I do a PEEP study on AC-PC, where I'm using the Phigh as the PC setting, and I'm doing the optimal PEEP study, often the measured P low, again, remember, we do an expiratory pause, and we look at that plateau, and then we freeze the waveform. Okay? Very often, the P low over here is within plus or minus 1 of the actual ideal peak. So it kind of backs up what Dr. Nadir did, his studies and the suggestions using the time-controlled adaptive ventilation, TCAV. You can look at TCAV and Dr. Nadir to understand this whole method of using specifically APRV with this auto-release. If I would take it off, it'd be like traditional APRV where you can set the P low. Now they don't suggest, since this here, it's never going to allow us to expire down to a very low P low level. So we don't have to set that because this thing is continually doing the calculation. It's always going to put it in the lung in the optimal position on the pressure volume loop. Okay. So why keep the P low? Well, if I'm starting to add a PEEP, what happens is you're engaging the PEEP valve, and PEEP valve causes obviously resistance and back pressure. That's how we create PEEP, just like a PEEP valve, right? It's just resistance on expiration. Now, mind you, we're not using, we have a very low T high, so we're not like, you know, there is some T high level that's optimizing a bit of the diffusion. But basically to say APRV generally, because we're staying up here, there's a lot of diffusion, so we want to expire without any resistance because that back pressure usually is quite concentrated with CO2. Okay, forgive me for that APRV tangent. So again, reference, control, we are looking at the end expiratory lung impedance, which equals end expiratory lung volume in a way. So we reduced it. Now watch what happens when we reduce the Phigh by 2, okay? I'll get close because there's subtle changes. Okay, all of a sudden, blue means that there is an increase of distribution to that level. Okay. So this is going to tell you, due to the changes, where are you gaining and where are you losing? So we're actually gaining at an important gravity-dependent area. So we reduced the Phigh, we reduced the pressure, and we're actually getting better distribution here, which often can indicate over distension, right? We went down low, maybe we were too up there, and then the lung was kind of overinflated, and that reduced the compliance, and the lung was a bit overstretched. So now that we reduced it, we're actually gaining a lot of blue, and that's a good thing. Now, you don't want to make changes and get blue up here and no response here. It just means everything that you did is going up on the ventrals, and that's indicative of over distension. So blue is not always necessarily good, and orange is not necessarily bad. If I see a lot of orange here and a lot of blue here, it means that the tidal volume has been redistributed in the area that we want. Okay, so see, we're doing good stuff, and I was able to wean the the FiO2 from 100, and I believe we are down to, give me a sec, I'll pause. And we're quickly weaned down by 20%. This patient, like many COVIDs, has just been hovering and staying on 100%. And by using continuous monitoring at the bedside, we don't have to guess, and we're not just we're not just using the SpO2, we're not using the pulse oximeter only as a compass to guide us. Now we are looking inside the lung through the electrical impedance tomography technology, and we're actually able to see where the air is going. We usually do global mechanics here. That doesn't tell you where regional distribution is, and that's what's amazing about Draeger and the Pulmovista. I'm looking a little further back in history. This was at 20, I'm going 30 minutes now back to where we are presently. And when we first changed, initially, before things started getting looking blue, we started with a reduction in the Phigh. We started seeing actually a loss in distribution at these ventral areas. What's that mean? If I'm losing here, it means that it's going probably in the correct area. So it's good actually when you lose orange at the top, because you don't really want that tidal volume always going up to the ventral and mid-ventral areas. So we're losing a lot here. I'll go a little faster. And now you're going to start seeing some blue appearing here, which is a redistribution. We're losing up here in the ventrals, and we're starting to gain at the mid-dorsal and dorsal region, which is fantastic. So I don't want to make the video too long, okay? But we can see region. This is global, and then we can see what's happening here with the impedance on the 4 regions of interest. We can see it this way, and we can see like a trend. That's very useful. But we also have the numbers. Global impedance. If you are negative, it means that you are losing volume, and that's not necessarily bad. If I'm losing a lot of volume up here, okay, that's a good thing, okay? So with the reduction, we didn't necessarily gain a lot at the dorsal region, very small amount, but we did lose a good amount here overall. Okay, I'm just curious. Let's do 50. All right, so let's kind of look at what's going on here as I move stuff over. Go a little faster. So losing in 2, gaining a lot in 3. Excellent. Gaining, oh, wow, losing a lot up here and gaining more here. That's wonderful. Now we did this by reducing, okay? So this lady was well recruited, okay, because don't forget she had a normal 8% at the region 4. But what's happening, it's telling me that when we're at 34, we were actually, yeah, well recruited at the base, but we were probably starting to over distend because all that volume was being distributed previously. If we look at the reference, there's a lot of that stuff was being distributed up here. If you're seeing a loss up here, indicative of over distension, okay, then you're gaining at the bases. That's telling me that she's more compliant. We were a tad high, and we were getting that non-compliant higher level of your pressure volume loop. Okay. All right. Thanks, guys. I highly suggest that you check on my channel. I believe it's called Step-by-Step APRV Setup, and because we did talk about APRV, but it was mostly focused on the Pulmovista. But if you're interested in understanding the specifically the APRV with the auto release on Draeger's excellent ventilator, I love this ventilator, you can check that video out that I made. And you can also look at my playlist. Go under APRV, Dr. Nadir, specifically from the Global Draeger. So I added that to the playlist. There's like probably 6 or something videos specifically on that, explaining about the auto release, the 75, all of that great information. So I encourage you to go see that video as well as the playlist. All right, thanks guys.